Good morning, everybody. I'm happy to present with Carmen Portenkirchen, a fifth-year resident, lecture of today about hereditary non-polyposis colorectal cancer. It's a challenging topic where there are some new facts. It's an open debate how to treat, and we will try to shed a light on it.
Good morning, everyone. We are talking today about hereditary non-polyposis colorectal cancer. First, we're going to have a look at a short introduction, then about microsatellite instability, as it is very important for HNPCC, and we see a differentiation between sporadic cases and hereditary cases. Then we will have a closer look at Lynch syndrome, which is also called HNPCC, and its genetic features. We will continue with treatment, follow-up care, and very important surveillance. So for a short introduction of colorectal cancer is the second most common cancer in male and the third most common in female. We have a familial accumulation in up to 30% of the colorectal cancer patients, and they are not presenting with a specific genetic cause. First-degree relatives such as siblings, parents, children have an increased risk for developing colorectal cancer by the factor 2 to 3. Maybe you remember from my last talk, which was about microsatellite instability, this pie chart. Here in blue, we see the microsatellite stable colorectal cancer part, which appear in the colorectal cancer up to 85%, whereas the microsatellite unstable part makes up 15%. In colorectal cancer, today we are having a look at the microsatellite unstable. Today in colorectal cancer, in stage 2 cases, there are up to 22.5% of microsatellite unstable cancers. This is important especially for prognosis because they have a better prognosis compared to microsatellite stable cancer. So today we're talking about these 3%, which are not much as you can see, and these are the Lynch syndrome patients and the HNPCC. I'm sure you all remember this slide as well, which was about immunohistochemistry of these 4 genes, MLH1, MSH2, MSH6, and PMS. If we do not have a loss of the staining, in immunohistochemistry, we're having a microsatellite stable colorectal cancer, whereas if we do have a loss of these genes, MSH2 and MSH6, we have a high suspicion for Lynch syndrome. Whereas if we have MLH1 with or without PMS2 loss, we have to perform further testing to find out if we have a HNPCC or a sporadic case. I'm sure you remember. So now we are going to go very short into genetic details. Here we see the DNA relaxing. What are microsatellites? Microsatellites are repetitive sequences in DNA of nucleotides. There are 1 to 6 nucleotides. Here you see the nucleotides on the base pairing, and in this area we have microsatellites. As you can see, they're repetitive, and when we do perform DNA, or when our body performs DNA replication, here we have a high chance for mismatch. So microsatellite instability is the inability of mismatch repair proteins to go up there and fix the genetic errors at microsatellites. So here in mismatch repair proteins, these genes are responsible for deficiency in here. This is the MLH1 gene, as you already heard, PMS2, MSH2, MSH6, and the EpCAM deletion, which leads to an epigenetic inactivation of MSH2. You can see they're on different chromosomes on the P arm. I'm sure you all know this is the short arm. So there we also have to talk about sporadic microsatellite unstable colorectal cancer. The vast majority, not all of them, but up 80 to 90%, are caused by epigenetic silencing of the MLH1 promoter gene, which is a phenomenon that is associated with a CG island methylation phenotype. CG islands are in DNA strands and areas where lots of cytosine and guanine is present. What is methylation? We have a deamination, as you can see here, of the cytosine, which is then changed accidentally to thymine. We have a TG mismatch, and due to this, we have a mutation in the MLH1 promoter. So we were now looking at this part, which was actually this arm, we did perform a BRAF testing before, but I was not going into detail with this because we had this last time. We were looking at the promoter hypermethylation. If there's not a promoter hypermethylation, we have a suspicion of hereditary non-polyposis colorectal cancer, which is also called Lynch syndrome. Now, more than 100 years ago, there was a family G. One of these family G members went up to Dr. Worthin. She was concerned there were many family members, they had cancer. So there was a high accumulation of cancers in her family, and she was a little bit concerned about this. Dr. Worthin made this pedigree and had a look at the family in detail, and he was the first to describe the familial predisposition to cancer. But the story grew old. Dr. Worthin died, and then Dr. Lynch picked this up again a couple of years later, and he was the first one who reported cancer family syndrome. And this is where we are right now, Lynch syndrome. So as you now know, Lynch syndrome is the most common cause of inherited colorectal cancer. It's an autosomal dominant fashion, and we have germline mutations in these genes. We already heard about them. There are large deletions in the EpCAM, which is adjoining with MSH2 gene, and which leads to Lynch syndrome, and most of the time it's upper GI cancers that are associated with EpCAM. We also have the gene LRRFIP2, which is adjoining the MLH1 gene. This is defected due to promoter hypermethylation also in these parts. We have a lifetime risk which is really increased in Lynch syndromes for colorectal cancer. It's up to 70%, whereas a normal population has a 5.5% chance of developing colorectal cancer. Also, the patients are much younger. They are 44 years old at the time of diagnosis. And for Lynch syndrome, we don't only have colorectal cancer. Lynch syndrome is associated with lots of additional other cancer sites. So maybe a question to my colleagues. I'm sure you can name some of additional cancer sites. Just give us a few examples.
Endometrial cancer.
Very good. Someone else?
Gastric cancer?
Yes, very good.
Bladder cancer?
Yes. And prostate cancer. So here you see there are lots of additional cancer sites. Very important. Endometrial cancer appears up to 60% of female patients, of course. We have small intestine cancers, hepatobiliary cancers, gastric cancers, lots of cancers which are associated with Lynch syndrome. So I want to introduce you a very important homepage. It's called Lynch syndrome cancer risk. You have a patient in your outpatient clinic, and they have immunohistochemically testing, and you want to explain them what does it mean for the future. So if we have the cumulative risk for developing cancer in any organ, our patient is 25 years old, he or she has a genetic variation in the MLH1 gene. We can have a look at the age of 50, he or she has up to 40% chance of developing cancer. When we now have a closer look at the specific organ for colorectal cancer, a male patient with MSH2 genetic variation has, at the age of 50, a percent of 15.8% of developing cancer. If we now change the sex to female, remember 15.80, I'm switching. Now it's nearly double. The female has, with this genetic variation, and double a risk for developing colon cancer. If you now change the gene, it's lower. So MSH6 is lower than MSH2. So it is important which genetic variation is present. And we can also look at this homepage at sigmoid rectal cancer. We will come later to this. It's a very important tool, and I think you can always look it up. It's interesting as well. So here we see the gene variations which are different for each additional cancer site in Lynch syndrome patients. So as we now know, inheritance is autosomal in Lynch syndrome patients, but we have to talk about penetrance and expressivity. I'm sure you all can remember your genetic lessons at university. What is penetrance? Penetrance are persons with a specific genotype which is exhibited as a phenotype associated with this genotype, whereas expressivity is a given phenotype which is expressed on a phenotypic level. So maybe I can make it a little bit easier with an example. If we have blue eyes and if we have brown eyes, we all have a brown coding protein in it. It's called melanin. And due to penetrance, it makes the difference if the melanin is more expressed at the higher level, then we have brown eyes, whereas in blue eyes, where we do have melanin as well, which is then expressed in a lower level. So this is penetrance, whereas expressivity is if we're looking at brown eyes, a few of them are lighter and a few of them are darker. This is due to expressivity. So here in Lynch syndrome, it is important that we do have penetrance. As you saw on the slides before, it is important to know which gene is mutated. It's age-related, and not every single mutation has the same risk for the additional tumors. And expressivity is very variable in Lynch syndrome patients. There are a few criteria and guidelines to identify patients if we should perform further testing. Maybe one of my colleagues knows them. I've already gone too far.
I think we already saw them. It's the Amsterdam Bethesda criteria.
Yeah, sorry, it was too easy, but I'm sure you knew this anyway. So the Amsterdam and the Bethesda criteria. We are not going into details due to time reasons and other reasons I'm explaining. So Amsterdam criteria, we are identifying a family. We're looking at the members. They have to be 3 effective members in 2 generations, and one has to have colorectal cancer under the age of 50, whereas Bethesda guidelines, we are only identifying individuals. The Bethesda criteria are very often misunderstood, and it is really important to know that these are for individuals which then should be performing MSI testing. It's less specific. But Amsterdam criteria and Bethesda criteria, they are old-fashioned, and up to 30% of Lynch syndrome patients can be missed if we only perform this. So there was a working group of these experts, and as well as other Lynch syndrome experts. They met together in Jerusalem in 2019, and they talked about this topic, and they considered, and the conclusion was that if a patient with colorectal cancer who is under the age of 70 must be screened with immunohistochemistry. They also made a conclusion for surveillance. We will come up to this later. So every patient, now we know about Lynch syndrome, we know how to identify them with immunohistochemistry. So now the patient is in our outpatient clinic, and we have to give them some options for treatment. And in the guidelines, there is a clear recommendation: no prophylactic colectomy or proctocolectomy should be performed in HNPCC mutation carriers. A subtotal colectomy in patients with cancer has to be discussed with the patient. We're having now a closer look at the grading, because it's really important, and I want to get this in your heads. If we have a patient with Lynch syndrome, we have microsatellite unstable, it's always a lower risk compared to colorectal cancer, which is microsatellite stable, is high risk, and BRAF is even most aggressive, but we're not talking about this. So low risk, it's always low risk. MSI colorectal cancer, low risk. So surgery in colon cancer, you can either perform a total colectomy with an ileorectal anastomosis versus an oncologic segmental resection. This is definitely to discuss with the patient, especially as we have a risk for developing metachronous cancer in up to 16% over 10 years. But, homepage again, look it up. We have a patient with the colorectal cancer. He or she is 45 years old. We have a genetic variation of the MLH1 gene, and in 15 years, or when the patient is 60, we have a 25 risk for this patient to develop a subsequent cancer. You have to keep this in mind, whereas in another gene variation, it's not as high. And this is also what Mella et al. Looked at. He investigated and had a look at over 1,300 patients. And you also saw and described that there's a genetic variation, but the overall survival does not differ. So when it comes to should we either perform a segmental resection or total colectomy, it depends on the gene. So in MLH1 and MSH2, we have a recommendation for extended surgery, although there is not a improvement in survival, whereas in the other gene variations, there is no evidence to support extended surgery. But the decision should be made gene-related, gender-related, age-related. Whereas in rectal cancer, we have it a little bit different when it comes for treatment. So in rectal cancer, the lifetime risk for patients with Lynch syndrome to develop rectal cancer is 20 to 30%, and the primary rectal cancer risk is up to 20%. So we nearly have the same risk for this. But it is important. The chance for developing metachronous colon cancer is 50%. As you saw in colorectal cancer, for developing rectal cancer, it's much lower. So patient, bless you, so patient with rectal cancer have mostly rectal cancer as primary cancer. And it is important when you come for treatment here, we have a chance for having rectal cancer and developing colon cancer as in a metachronous way, whereas in the other way around, we don't have so. This should be taken in account when we talk about with the patient about treatment. So a restorative proctocolectomy with an ileal pouch anal anastomosis should be a personal decision, should be looked together with the patient, and the gene-related, age-related decision should be made. We don't have data that supports total proctocolectomy. So after oncologic resection, we have to have a look at the patients, which is still ongoing. We have to perform colonoscopies on a yearly basis. So we have to have an intense surveillance for patients which are only undergoing a oncological resection, but the extent of the surgery should be discussed with the patient at the time of the diagnosis, especially in young patients. But we don't have a prophylactic treatment in colorectal cancer, but we do have a clear need for performing prophylactics, salpingo, orthorectomy, and hysterectomy in patients, in female patients, over 35 years old when they finished family planning in postmenopausal women. So here we should perform prophylactic surgery, and maybe with young patients we can discuss it with then wait for the colorectal cancer to appear and do this together in one procedure. Adjuvant therapy. There is a lack of benefit from F5FU-based adjuvant treatment in stage 2 colorectal cancer. A trend is even again towards worse survival, especially also in the ASCENT database mentioned. But in stage 3 tumors, we don't have, there's some data saying that there is a benefit, but there is also data saying that there's also a lack of benefit of the 5FU-based treatment. There is a benefit of oxaliplatin-based adjuvant chemotherapy in any status, but also newest research showed that this actually has to be challenged. So we don't have a treatment guideline that does recommend adjuvant chemotherapy here. There are checkpoint inhibitors. They have a novel approach to overcome immune cell exhaustions. In particular, antibodies are blocking the PD-L1 pathway, and it has to be shown, has shown clinical efficacy. Checkpoint inhibitors are not organ-related, but they are mutation-related. They are the first FDA-approved drugs that are not organ-related, and there has to be shown that there is a good response to immune therapy, especially in metastatic disease. So for prognosis and prediction, MSA Lynch syndrome has a predictive role for resistance of 5FU. We have a good response to immune therapy, and it's a favorable prognostic biomarker. What is important now? We identified our patients, we talked, we had a look with them, we did perfect treatment for them, we had a look at adjuvant chemotherapy, and now it's important, what should we do with the next generation? The next generation has to be screened before the age of 25. Annual colonoscopies should be performed every 1 to 3 years. Upper GI endoscopy has to be performed, and in women we have to perform annual gynecological examinations with tumor markers and biopsies. To finish this chapter for treatment, I want to show you the CAP2 trial, which was published in Lancet from Sir Dr. Byrne. 600 milligram of aspirin for a mean of 25 months reduces colorectal cancer incidence after 55 months in patients with mismatch repair, but not in patients which do have a mismatch repair mutation. So now we treated our patient. And now we can kind of do a short summary. Here we do have the heterozygotes. So Lynch syndrome is the most common inherited colorectal cancer. It is important there is a gene-dependent age-related penetrance, as you now all know. We have gene-dependent increased risk for other malignancies. You have to perform a lifelong surveillance in these patients, and the extent of surgery is not clear right now. It's a matter of debate, and it's still going on. Thank you for your lovely attention. Thank you very much.
And I want to thank you for the fire in the belly. It was very nice, very enthusiastic. So congratulations, very nice presentation. And we realize here how much we need to know about genetics and now immunology. So things have changed for your generation. It's probably clear. And for other people, they probably need to go back to the book and learn better about the immunology and the genetics here, that it's clearly very important. We cannot just treat what we see on an X-ray. We need to understand a little bit better what's going on here. And I may start to ask a question. I mean, obviously there is some in this HNPCC, there is clearly some genetic predisposition, etc. I mean, and this is epigenetic, what I understand too. So the risk factors for colon cancer that we have, smoking or others, are they enhanced, or could we prevent also this cancer to occur when you have these genetic disorders in these patients?
Well, I guess for the sporadic microsatellite unstable cancers, the risk factors are probably indistinguishable from normal colorectal cancer in a way. They have different features, but this is just a different way of, carcinogenesis. For the HNPCC, for the Lynch syndrome associated patients, I am not sure if we have reliable data on, risk behavior, if this is really a manifestation factors. I think this is a very, different pathogenesis. I guess, from an oncologist point of view, I mean, you very nicely really mentioned the big challenges we face. We have a dramatic change of treatment in those Lynch-associated stage 4 cancers, which were really difficult to treat. You had these young patients, poor response to chemotherapy, very difficult to treat. And now we have immune checkpoint inhibitors, and we see dramatic responses. We see complete remissions. We see long-term survival. There might even be cure for some stage 4 patients possible now. So this is a dramatic change, also a very, very good message for these patients. And the other challenge is stage 3. What are we going to do with adjuvant chemotherapy? There is more and more data accumulating from gastric cancer that, adjuvant or perioperative chemotherapy is not a good idea. These patients do not benefit. They might even have, worse, inferior outcomes. So how are we going to, treat these patients now in clinical practice? We're now performing, mismatch repair analysis in all these resected colorectal cancers, and then we have to debate. This is stage 3. Guidelines say give FOLFOX, but is it really a good idea? Of course, I mean, everyone would argue we should give immune checkpoint inhibitors, but they have not been studied or approved in this setting yet. So this is, I think, is a big challenge, and this is not rare because this is in earlier stages, 15-20% of cancer. So I think these are really the big challenges, how to treat with these patients at the moment, from my perspective.
A great talk. Just one question to that. I mean, if we have a patient, he has liver mets, he is microsatellite unstable, do we give pembrolizumab? Do we give a checkpoint inhibitor?
Yes, we do. There's, there are now first-line trials, the first-line trials even, comparing or randomizing chemotherapy against immunotherapy, and the first trials have finished recruitment and we're waiting for data. Now, of course, we would like to give first-line immunotherapy, probably combination immunotherapy. That's very nice first-line data out with a nivolumab and an ipilimumab combination, very high response rates, very, very, very good survival. But of course, there's this kind of issue of regulatory approval. So we have to, talk to the insurance companies and try to get coverage for this. So in practice, frequently we start chemotherapy and then in second line we go for immunotherapy. But no one knows if this is a good concept. I think so the paradigms are shifting to first-line immunotherapy, and I think everyone would, put some money onto the fact that in 2 or 3 years we will go straight for immunotherapy. But this is evolving.
You talked about the next generation. What about pre-implantation diagnostics in this field? Is this issue or not? Does anybody know?
So there's no role of pre-implantation diagnostics, to my knowledge, at this point. I think you've very nicely outlined the concepts of penetrance and expressivity in this disease, and I think it's very important from the pathology perspective to highlight that this is very heterogeneous as a subgroup from the clinical presentation. Even though it's called hereditary non-polyposis colorectal cancer, there's patients that do have polyps. About 10% of these cases have more than 10 polyps. So even a patient that is presenting with a young age with a higher number of polyps can be an HNPCC patient. Also, if we talk about testing, we're using the immunohistochemistry as you outlined, but there is a small subgroup that don't show loss of one of the proteins, even though they have a Lynch syndrome, because they don't have truncating mutations, but have spot mutations, right, point mutations that lead to a functional loss. So I think we need to be very careful in looking at this disease and making decisions about pre-implantation diagnostics, which are very, these are very severe decisions, because not every patient will act the same, and this will impact these sort of decisions also in the future.
Can you tell us a little bit shortly about the screening of the other cancers that might occur in this syndrome? You mentioned the colon and you mentioned the gynecological tumors. What about the other ones, especially upper endoscopy? How often should we do that? Is maybe the current guidelines here?
The gynecologist, the female patient should go there yearly, and she showed nicely as well as the gastroscopy. The other surveillance examinations, like for bladder cancer, are not regulated. It's gene dependent. Probably, it's the upcoming knowledge. We don't know exactly when a patient should be tested in which gene because we don't know exactly which organ is at risk. We only have in this database of the prospective. It's a very interesting Lynch syndrome database, and there is upcoming knowledge which gene is responsible for what organ. So probably the guidelines will change. But for other organs, then colorectal, gastroscopy, and gynecologist, there is no regular surveillance up now. And as she also mentioned nicely, nobody knows what interval should be used, because there is an interesting publication about the comparison of German guidelines to Dutch guidelines to Finnish guidelines. And in Germany, the colonoscopies are yearly, in the Netherlands every 2 years, and in Finland every 3 years. And there is no difference in the survival of the patients.
Very nice talk. I have a question concerning the prophylactic treatment. You made it very clear that there is no recommendation on prophylactic colectomy, but is this, you mean primary prophylaxis, not colectomy for the next generation, or colectomy when you have a carcinoma? And how comes that the recommendation for gynecological manifestations are so clear that you should go for prophylactic resection when the etiology is the same? How comes that is a difference between colon and gynecological manifestation?
The recommendation she made for no prophylactic colectomy is for patients which have the inherited autosomal dominant mutation but no cancer. So there is no prophylactic surgery in these patients. There is no indication. If they do have a cancer, a colon cancer, let's talk about this, you can either go for an oncologic segmental resection and take the risk that the patient will develop a metachronous cancer, but this is the one risk you have, or you go for a total colectomy. You have zero risk of another colon cancer, but you have a somewhat larger operation, and you don't know really if you really need it, because not every patient will develop a metachronous cancer. That's why they look at the different genes, and so they are gender-related, age-related, and gene-related for making up a decision in discussion with the patient. And then there is a difference when you do have a colon cancer, you really only rarely develop a rectal cancer. But the other way around, when you do have a primary rectal cancer, it's quite high risk to develop a colon cancer. So the treatment is different. When you do have a primary rectal cancer, the recommendation probably will be upcoming by the European Hereditary Tumor Group for a total proctocolectomy, but not the other way around. The reason why the hysterectomy should be performed is because the risk for endometrium cancer increases by age, and females after after their reproductive age do not need really the uterus anymore like you would need your bowel. That's the difference probably. It's a very pragmatic approach, but you don't need this organ at that age anymore, but you do have a risk of 60%, so you can take it out.
Thank you very much. Thank you.